First of all, yes, anesthesiologist, pain doctor, South Health Campus, one of our big hospitals. Just a little bit of context, we do a lot of regional anesthesia nerve blocks at our hospital, which you'll see in the presentation. And compared to some other hospital settings, we have a lot of ambulatory surgery. I wanted to just identify that I have no conflicts of interest, and I do have a ton of acknowledgements. Thank you to all of my family at the CPC. They've supported me from the inception of my career, and also to innovators like 𝐒𝐂𝐂𝐂𝐂 and other anesthesiologists and all sorts of people that are out there doing, boots on the ground, doing the research to show whether or not what we're doing in transitional pain services is helping in the long term. I would say that I'm standing on the shoulders of giants, but I don't think I'm standing quite yet. I'm piggybacking at the moment. One day I will stand. So this is a bit of a practice profile of mine. A lot of the themes are overlapping with what Rosa said, because we do work together in the transitional pain service there, which was founded by myself, Dr. Jared Stephan, another anesthesiologist, and Rosa in 2017. So I've been working at it for 5-6 years now. So I called this talk First Do No Harm, because what I see happening over and over is that before we decide to traumatize the tissue with surgery, we are supposed to consent the patients. And the patients have consent discussions with the surgeons, and the surgeons will list pain, sometimes persistent pain, as a risk, but the issue isn't fleshed out often. So I think we have an opportunity understanding pain a bit more to help patients figure out whether or not they would really like their elective breast surgery. We have a number, like I said, ambulatory center. We have a number of high-risk procedures that we do commonly there, like the inguinal hernia surgeries and the breast surgeries. So sometimes, this whole issue is even laid to rest because patients will decide not to have surgery when they fully understand the potential risks. But say we do decide to go ahead with tissue trauma, the next most important thing is to figure out who really needs our support. So, if there is a magic potion, what are the ingredients? There's not a magic potion, but if there were, what do I think are the ingredients? And like I said, the first one is screening. So I'm going to apply this in the real world here. So this is a patient of mine. Not really, but this is a picture of somebody like a patient of mine, a 40-year-old female named Maria, who came to me last year in the transitional pain service. How did she get there? Well, one of my surgical colleagues has been fantastic and has started screening their patients. We don't know precisely what are the best screening tools right now. My dream is that one day all of our patients coming to the South Health Campus for surgery would be screened, hopefully using an app or some other online platform, so that we can pick off the ones where we're probably most likely to be needed or most likely to cause benefit with our interventions. But this shoulder surgeon did screen her patient before they came for surgery, and she lit up the BPI and the pain catastrophizing scale like Christmas trees. So this surgeon got in touch with me also because she was afraid of the amount of opioids that this patient was on. And she thought to herself, this is going to be a challenging thing for me to support this patient with when she has to go home from hospital after her total shoulder arthroplasty. So she sends this patient to me in the transitional pain service, and I say, fantastic, this is great. So we've tool number one, we've screened appropriately. Tool number two, I got to see this patient 6 months pre-operatively. So we have time to work with. That's the other key. If we don't have time, there's not much we can do pre-operatively. There's still a lot we can help with during the surgery and after, but ideally we would have the time up front. So a little bit more about Maria. She had, when I met her, a 20-year history of chronic daily opioid use since a motor vehicle collision that resulted in persistent low back pain and neuropathic pain. She also suffered with fibromyalgia and migraine. She presented with excessive anxiety, major depression with a history of suicidality in the past. Which brings me to the third most important point. I'm looking at the history, I'm reading all the notes, and I'm asking myself, what are the comorbid conditions here? And who do I need on my team to help diagnose them? I'm pretty good at making the pain diagnoses. Like I said earlier, one of the most common ones that I find is complex regional pain syndrome that hasn't been diagnosed. Now, CRPS is not common, but when it's there, it commonly goes unrecognized. So I can handle that. I can, that's in my wheelhouse, but certainly I often need support for psychiatric diagnoses and management, as well as medical diagnoses, other medical diagnoses. So Maria's maximum oral morphine equivalent before I met her had been 1,500 milligrams in the form of oxycodone. And her GP, who was ex-officio family doctor who was absolutely excellent, had flexibly weaned her down to 500 milligrams oral morphine equivalent a couple of years ago. And she felt at that point she could go no further. And so they kept it stable at that level. So speaking of the family doctor, that is my secret weapon. I wrote family doctors in right away, phone calls, emails, notes, certainly, but shared planning and shared treatment as much as possible, especially if the patient views that family doctor as a trusted ally. All right, so what do we have so far? We've got properly deciding whether or not we want to do surgery, screening so that we pick up these cases. We've got time to work with. We're optimizing, identifying, optimizing comorbid diagnoses, and we've got the family doc on our side. So what's next? So this is kind of where I start. I told you about how I center myself before I meet these patients. Developing rapport, getting inside of that experience, and allowing the patient to tell their story, to inform you as much as possible about what it is like to be them, what it has been like to be them. From a holistic standpoint, has to be the key. I understand this involves a little bit more time, but you're much better to spend that time up front, because otherwise you're wasting all of your time. Because unless they know that you know what they're experiencing, you will not be able to get any buy-in, and therefore most of your interventions and suggestions are a waste of time, like I said. So at the very beginning, we're hearing the story. And then we're looking for areas where we can personalize a pain education. So that message that the brain produces pain, all pain is produced in the brain all the time, is a difficult one to deliver, as you guys know. Preaching to the choir here, but those messages need to be gently massaged into the patient's experience with you based on areas where they might be able to pick it up more. So yes, for sure, we have sheets and we have podcasts and we have textbooks on pain, and we understand that it's important to educate our patients. But at the very beginning, starting that interaction with with our little spidey sensors up, here's an area where I could start that conversation is really important. And then we do give a handout. When we do that, we want to look through it with the patient and we want to say, hey, this might be a good place for you to start. Oh, you mentioned you're interested in mindfulness. Maybe Headspace would suit you. You check it out this week and then report back to me. We'll discuss it next week. And by the way, I email these things. So I'm summarizing plans, and whether or not it's putting me at risk from a medical legal standpoint, I'm emailing the patients every single time I have an interaction with them with their care plan. And this has dramatically increased my impact. Even writing a list of things to do before I talk to you the next time has not been effective in my practice. Communicating by email, typically is a one-way communication from me to them, has been a game changer. Okay, so we are educating people in terms of the nature of the experience. And we know that the more we know about pain experience, the less it can hurt. So as soon as we start to demystify that and be that voice that says, oh yeah, this makes sense. I've seen this before. You've been through a heck of a lot. Yeah, this is very real. To have somebody that recognizes a chronic pain syndrome, what is chronic pain syndrome, and to deliver those messages is absolutely key. Before we move on, we have to think back to Maslow's hierarchy of needs. I've had a patient this week who didn't have shelter or food coming her way. So if we're there, we need basically an immediate social work consult. We need to rope in, the resources that this patient needs to feel safe and be nourished and have her children nourished before we can start talking about anything else. So yeah, that's got to come first. I should mention, like Rosa did in her presentation, that we in the transitional pain service use ACT, acceptance and commitment therapy, which is kind of like your third wave cognitive behavioral therapy. We're the three of us trained in that. So constantly doing this dance between these different ideas, contact with the present moment, radical acceptance of where we are, diffusion, which is avoiding being hooked by hot thoughts, self as context. And then ultimately what we're all trying to do is to help patients live meaningful lives, like the lives that they would like to live. So most of these patients come in having a hell that they want to run away from, but then our role can be helping them build a vision of a heaven to run towards as well. And that's what ACT is ultimately about. It's about identifying values, making goals, and then breaking down the goals into bite-sized chunks and decreasing the barriers. So that is the background there. That's really meaningful. And this is also heavily based in mindfulness practice. I cannot move on without emphasizing the importance of physiotherapy. Prehabilitation is this process of setting somebody up from the perspective of just their physical fitness to present for surgery. When people are on surgical waiting lists, they often do just that. They wait because they are told you have a surgical problem, the surgeon will fix it. Now you must wait for 2 years, maybe more. So people become certainly deconditioned and they need guidance. They develop kinesiophobia and they develop, high sensitivity to pain. So we work a lot with physiotherapists, especially on decreasing that sensitivity. So that, and then occupational therapy, absolutely important role here. We need OT planning, detailed OT planning, and we need to have that conversation about work, the value of work. If our aim is to make these patients feel safe, if we believe of this, danger messages versus safety messages, then who feels safe if they can't earn a living, right? This is an essential piece to bring in early. All right, next, so what do? We talked about rapport, pain education, where we are on our hierarchy of needs, using a cognitive behavioral therapy approach like ACT, prehabilitation, desensitization, reducing kinesiophobia, detailed OT planning, and connecting with employers. So this brings us to the world of non-pharmacologic pain management. This is an area where the evidence is so wishy-washy, but what we're trying to do essentially is I literally have people buy duffel bags and I get them to pack their pain coping toolkit to bring with them into the hospital or to have, at the ready when they come home. So this is more exploring what has worked for you in the past. Let's do trials of virtually anything that's low risk and low cost and bring it on in. So that could be things like TENS for this patient, for Maria, TENS therapy, aromatherapy, heat, cool, music. Those were her big ones. Oh, and I love this is my favorite prescription to write. This was a dog lover without a dog. So Maria actually did adopted a shelter, an older shelter dog about 4 months before her surgery. And honestly, if we had just done that, probably would have been sufficient. In this case, that obviously I don't prescribe dogs for everyone. All right, so non-pharmacologic pain management strategy, emphasize that stuff first. Then, of course, we have medications. You heard a lot from Rosa. I agree. I do all of the same things. I do talk to them a lot about opioid tapering if they're on opioids in a very sensitive and flexible way. Of course, I do like to taper opioids ahead of time so that my acute opioids that I will use around the time of surgery will be the most effective. And we reduce any of that central sensitization if it is there. Antidepressants such as the SNRIs and TCAs, pregabalin, gabapentin when it makes sense, marijuana products. I love the topical ketamine for neuropathic pain. And then other presentation specific therapies like migraine therapies, for instance. She also mentioned interventions, yes. So especially for these shoulder surgeries, total shoulder arthroplasties, we're starting now to do some suprascapular nerve cryoablation. So super cool, you can bring them in months ahead of time, you can decrease the pain with this cryoablation, you can prehabilitate them, bring them in, and then have some perioperative pain management. This can last 6 months or more sometimes. So that's a brilliant new area, but it's gotta be timed, right? So then we come to the day of surgery. We've done all of our prep, all of our med titrating, our cognitive behavioral therapy, our mindfulness training, resources, of the wazoo for pain education. And so then on the day of surgery, this is for me like really magical because I get to help orchestrate. So I am in contact with the block anesthesiologist that day, if I can be. They say, fantastic, yes, of course I'll do a brachial plexus block. Yes, of course I'll place a catheter in there. And then somebody like Rosa comes around and, connects them to a nice baby bottle before they're sent home. And that baby bottle infuses that local anesthetic there so we can keep a numb, dead shoulder and arm for a couple of days. And then when that infusion is done, they're over the hump. And then the infusion stops, the block wears off, and then they just need quite minimal opioid. In this case, obviously this patient required her same background opioid dose, but she used very little extra, all told, given the environment that she had when she came through her surgery. And then, this is a controversial topic. Absolutely don't use this for everyone. But later on, 6 weeks post-op, she was already talking about, coming off of her opioids. It was 20 years, we'd gotten down to 300 oral morphine equivalent before the surgery. So then often, this is a very neuroplastic time where there's a surgery, there's a change, there's a surgery, there's often a lot of hope around this time. And so then people get very excited and want to capitalize on it, which is great. One thing I absolutely love about the transitional pain service, but I find myself having to, actually pull back on the reins a bit in terms of opioid tapering. So we're taking it very slow. She's still in my practice now. She did wean down, with very close monitoring to, I think it was like 150 milligram oral morphine equivalent before we did a really slow cross titration to Suboxone. She came down to 2 milligrams BID on her Suboxone and found, this is hard. It's getting hard for me. We popped it back up to 8. Now she's using 8 milligrams once daily, and she's feeling great, actually. So this was a major success story. They certainly don't all go like this, but perfect world. This is what we're aiming for. So just by way of review, what did we do and what are we hoping to do with all of our patients? Screen them appropriately, consent them appropriately, have enough time to work with them, optimize comorbid conditions, rope in the family doctor, communication between family doctor and surgeon and us throughout, building the rapport, making pain education accessible to that patient in their specific scenario, meeting physiological and safety needs as much as we can, using a cognitive behavioral therapy approach, prehabilitation, occupational therapy, work planning, non-pharmacologic pain coping toolkit to put the ball in that patient's court to help them feel safe, to help them feel effective, and a partner in their treatment, not just kind of passively receiving treatment. Opioid weaning when it makes sense, medication trials, interventions, close coordination on the day of surgery with the nerve block team, the anesthesiologist in the room, in this case, nice GA, dexmedetomidine sprinkled in there, a lot of really nice things there to wake them up nice and happy, preventing that, acute pain flare that happens for a lot of our patients coming through here who are complex. And then ultimately close follow-up after, calling frequently, getting inside of that experience again and helping to grease the wheels as much as possible. Thanks so much for listening.